All right, it is Thursday. It's week 5. It is the winter of 2022, and it's gastrointestinal pathology day. Here we go. So we're getting started on the stomach. We're leaving the esophagus. Now, if you need a physiology review on the stomach, make sure you watch this video because I assume you remember your GI physiology. This is the stomach. Hopefully you know what that is. There's the esophagus, the abdominal part of the esophagus we just finished up talking quite a bit about. And yep, the stomach attaches, of course, to the duodenum and duodenum, duodenum, however you want to say it. Tomatoes, tomatoes. I call it duodenum. And yep, there it is. The regions of the stomach are a little different than in pathology compared to anatomy. Anatomy, remember, there's a cardiac region right here, there's a fundic region, a body, and an antral region or pyloric region, or you could call the pyloric antrum, and then there's a pyloric canal. There's the powerful true anatomical sphincter called the pyloric sphincter, lives right there and doesn't let undigested food pass into the duodenal bulb here. Now, pathologists, they don't recognize a fundus, they don't recognize a body, they don't recognize a pyloric canal. There's 3 regions. In their eyes, there's 3 regions based on the glands that live in these regions. There's cardiac region here in pink. There's the fundic region right here, sometimes called the oxyntic region in blue. And there's the antral region or pyloric region that is right here in green. And those are named because there's cardiac glands, fundic glands, and pyloric glands that live in these areas. So that's how they name them. Another term that's confusing is the term stomach glands. You would think this would be simple, but of course it's not so simple. I will use the term stomach glands to collectively describe all of these cardiac, pyloric, and fundic glands. So that's a general category. Those glands, those are all the stomach glands, cardiac glands, fundic glands, pyloric glands are all, if you want to use one word, stomach glands. Some authors use gastric glands as the main category and not stomach glands. Why isn't that not a good idea? Because some authors use the term gastric gland as an AKA for the fundic glands or oxyntic glands. So that's not a great general term for the 3 types of stomach glands. And there's the 3 again: cardiac, fundic, pyloric. Fundic has some AKAs, oxyntic, gastric. Remember, these are the ones that contain parietal cells and chief cells. Pyloric glands, nobody really calls them antral glands. I guess you could, because pyloric and antral are AKAs in some texts. They contain the G cells. And okay, the fundic gland, let's just take a look at the fundic gland is right here. The official gland is the isthmus to the base. This is the fundic gland. It contains parietal cells, and it contains chief cells, aka zymogen cells. Most people call them chief cells. And then there's some stem cells in this isthmus region that produce all these cells and produce all these mucose cells or foveolar cells that are born in the isthmus and are kind of pushed upwards. I don't know why that parietal cell or parietal gland is sitting there. It should not be. It should not be there. All right. So parietal gland. What else did I want to say? That's about all I wanted to say about that. Now, the next concept is the gastric mucosal barrier we need to talk about. So what's the story with that? Again, watch my YouTube video if you need a refresher. I'm not going to go into the weeds too much on this. But this is basically the mucus layer that lines the stomach and protects it against the wicked acid that lives in the stomach. Okay, the mucus is made by those foveolar cells, these guys right here. Right, and again, we're looking at the oxyntic gland. And those are, did I call those parietal glands? Those are parietal cells. I knew something was bothering me there. And these are chief cells or zymogen cells. Okay. And so these mucus cells, these green ones right here, as they get older, they produce mucus. These are mature mucus cells here that produce mucus and bicarbonate. And PGE2 comes out the bottom of these. These immature ones produce just a fluid, more like a watery fluid that sweeps into this lumen and pushes hydrochloric acid upwards. So I took all that part, but if you don't remember that, you can go look at my more in-depth video on that. So the gastric mucosal barrier, again, is made by these foveolar cells, those green ones on the top. And they secrete, you should know what foveolar cells or mucose cells secrete. Well, they secrete mucin. It should be mucin here, not mucus. Mucin plus water equals mucus. So mucin bicarbonate, which neutralizes acid, and then something called PGE2, which doesn't go into the lumen of the stomach. This goes into the interstitium. It comes out the basolateral surface of foveolar cells. So let's look at this little cartoon. These are mature. These are those little green foveolar cells here. So they secrete mucin, which mixes with local water that's floating around and becomes mucus. They secrete bicarbonate here, which can neutralize acid. And this is the lumen of the stomach where the hamburger is sitting. And out the bottom, the basolateral surface is the bottom of this cell. That's where PGE2 is secreted. As we'll see again later, PGE2 is very important for kind of calming down the acid that comes in the stomach. How does it do it? PGE2 will swim over here and it will bind to ECL cells, which of course make histamine, and it discourages the production of histamine. If you discourage histamine, then you discourage histamine from binding to a parietal cell. And parietal cells, of course, are what make hydrochloric acid. They are hydrogen ion and chloride. And they also make pepsinogen as well through the... they make pepsinogen. Well, no, they don't. The pepsinogen is made by the chief cells, not the parietal cells. All right, so that's the story there. PGE2 is also interesting because it has an autocrine function where it turns around and binds to itself, and it stimulates the cell to produce mucus and bicarbonate ion. So it also swims over to the next door neighbor and binds to it and stimulates it to produce mucus and bicarbonate ion. So therefore, PGE2 is autocrine and paracrine. Got it? All right, let's go down the rabbit hole here and talk about NSAIDs a little bit. Because backing up here, to make PGE2, there's an enzyme that you need, and that's called cyclooxygenase 1. That's with cyclooxygen, we won't get into the weeds on it, but cyclooxygenase 1 makes PGE2. All right. So in order to release PGE2, the enzyme cyclooxygenase 1 must be functioning within the cytosol of a mucose cell. Its job is to create the molecule PGE2. We won't worry about the substrates and how that's made. Right? PGE2, as we just said, it basically makes and protects the gastric mucosal barrier. Right, so there's actually two cyclooxygenases. COX-1 is ubiquitous, meaning it's everywhere in the body, and that's amongst other things. It causes pain. It can get onto nerve endings, as we'll see, and stimulate them and creates the sensation of pain. But in the mucose cells, it makes PGE2. There's also a COX-2, which is normally non-functional in mucose cells. It can wake up if COX-1 is blocked enough, but it's usually not. Okay, so in a pinch, it can make a little PGE2 if you're taking a COX-1 inhibitor, for example. COX-1 and COX-2, that should be 2. COX-1 and COX-2 enzymes are always turned on in inflamed and damaged tissue. All right, so both COX-1 and COX-2 are also involved in driving the process of inflammation, like a sprained ankle. More specifically, their job is more cleaning up dead tissue and initiating the healing process. And that's going to bring us into the little babies like, oh no, here we go, into the inflammatory cascade, which I do want you to, oh my God, you don't have to memorize everything here, but you should know a little bit about this inflammatory cascade. So go back to this picture. So this guy sprained his ankle. And some of the the cells of the ligaments and the cells of the muscle have been damaged in the injury. And their membranes have exploded. Fragments of phospholipids from the damaged tissue are now floating around in the ankle. And there's an enzyme called phospholipase A2 will grab those damaged, broken down fragments of the cell membrane, the phospholipids, and convert them into arachidonic acid. Now, arachidonic acid, and this is the inflammatory cascade again, it can go two ways. We're not going to worry about this. By 5-LOX can take it down the leukotriene pathway. We're not going to worry about that. I'm worried more about pathology, so I want to go down this PGH2 pathway, if you will. So COX-1 and COX-2 both are used and both can convert arachidonic acid into this main molecule here through an intermediate, we won't worry about PGG2, but into this main molecule called PGH2, prostaglandin GH2, PGH2. Prostaglandin H2 can go three ways. It can be converted into our friend PGE2. PGE2, of course, and that's done by I should have had COX-1 up here. But PGE2 can then, of course, stimulate and help promote the gastric mucosal barrier. I see what happened. This moved. So COX-1 should be over here. All right. PGE2, by the way, is also involved with binding to pain nociceptors in and around the damaged tissue and creating pain. It also can get into the bloodstream and cause fever. All right, so that's one pathway. And that pathway is dependent on the COX-1 enzyme. COX-1, again, makes PGE2. Right? So now can you see why if you take a COX-1 inhibitor, if you block the COX enzyme, you can't make the gastric mucosal barrier. Right? It discourages the formation of the gastric mucosal barrier, and the acid naturally produced in your stomach will start to irritate and inflame the lining. Right? That's why COX-2 inhibitors don't do well. They're rough on the stomach. There's another pathway I want to look at. So PGH2 can also be created or be turned into two important enzymes. Prostacyclin is one of the slippery three. That's an anticoagulation molecule that discourages blood clots to occur in the damaged tissue area. It also can drive or create something called thromboxane A2. That's a powerful procoagulant molecule. That's a thrombogenic molecule, so that will cause a coagulation. It also causes vasoconstriction. This one causes vasodilation. So normally, COX-2 is a cofactor and helps prostacyclin 1 synthase make prostacyclin. So COX-2 is responsible for that. COX-1 is responsible in combination with thromboxane synthase of converting PGH2 into thromboxane A2, which is a coagulator. Right? So now can you see a problem if you take COX-1 inhibitors? If you take COX-1 inhibitors, it's going to block this pathway. And instead of some half of the PGH2 going this way and half going this way, all of it's going to go this way. So COX-1s are going to overproduce prostacyclin, and therefore you're going to have trouble bleeding. That's why you have to stop all COX-1 inhibitors before a surgery, because you will bleed. Why? Because the thromboxane A2 is going to have trouble being produced if you're on COX-1 inhibitors. The opposite side of this story, if you take a COX-2 inhibitor, it blocks the formation of prostacyclin, and the pathway, instead of going this way, everything goes this way. So you overproduce thromboxane A2, and therefore you're more prone for coagulation. So people who are thrombophiliacs, people who have a blood clotting problem, they have to be very careful. They shouldn't really take COX-2 inhibitors because it will decrease prostacyclin and overproduce thromboxane. In other words, you're at greater risk to develop a blood clot if you're on COX-2 inhibitors. See how that works? All right, play it back if you don't get it. Listen to it again. Hopefully it'll sink in. So pretty much everything I already said. So COX-2 is a double whammy with regard to thrombosis. COX-2 knocks out the formation of prostacyclin, which increases the process of thrombosis. It also drives the formation of more thromboxane A2, and that is a powerful coagulant, or it's a prothrombogenic molecule, as we already said. Got it? All right, so in inflammation, the COX enzymes often become overactive, and that's why anti-inflammatories work so well, because the body tends to overdo it, and the inflammation process can start affecting the good tissue and not just clean up the bad tissue. So that's why anti-inflammatories can help a process like that. Who are the COX-1 and COX-2? Well, we just looked at COX-2. There's COX-2. Celebrex is the only. There is another one, but it's not very popular. There used to be one called Vioxx, which I used to really worked good for all my aches and pains, but that's been Vioxx tends to really drive the production of thromboxane A2, and so that's been taken off the market because of strokes, blood clots in the brain, blood clots in the heart, caused heart attacks and strokes. That one's been taken out. And then who are the COX-1? We know these. These are over the counter. Aleve, Advil, aspirin. These are all COX-1 inhibitors. Now, over the counter is not prescription strength. If you get prescription strength medicine, you can take this in higher doses, but it's the same molecule. Right? We already said it hinders coagulation, contraindicated in hemophiliacs. COX-2 hinders anticoagulation and is therefore contraindicated in thrombophiliacs. So make sure you know that, play it back, and hopefully you'll be able to figure that out. NSAIDs, both COX-1 and COX-2 inhibitors, they are not absorbed by the stomach. They're absorbed in the small intestine. That's why they should always be taken with food. Some NSAIDs, like aspirin, salicylic acid, is an acid, and it can burn the stomach, can upset your stomach, having nothing to do with the gastric mucosal barrier. So they should always be taken with food. Once they get in the bloodstream, they circulate around in the bloodstream looking for inflammation. Put it up again. Yeah, looking for inflammation, and they can block. They can block this first step, arachidonic acid, into PGG2 a little bit. They can also, because they're not going to completely block that step, so they can kind of double block it. They can block it. COX-2 blocks this one, and COX-1 blocks this one, and see how they can block different steps. I got to fix that though. All right. All right. So back to the stomach. So unfortunately, the NSAIDs will knock out the COX-1 inhibitor, and without COX-1 working, it's hard to make PGE2, which may be great for fever, may be great for pain, but it also knocks out the production of PGE2, therefore the production of mucus bicarbonate, and you can't inhibit the ECL cells. You can't inhibit the production of histamine anymore. So what? That's the same thing I just said. All right. So there goes your gastric mucosal barrier. And that's everything I just said as well. So you get over a regular production of acid from parietal cells and pepsin from chief cells. And you damage, if there's no gastric mucosal barrier, the acid burns your lining. And you get tummy upset. You get different gastropathies, which we'll talk about later. All the excess acid can start to, especially if you have any risk, if you have a loose lower esophageal sphincter, you're going to get GERD. And even worse, it can get into the duodenum and burn a hole through that and cause a peptic ulcer. Or it can burn a hole in the stomach too. In fact, there is a peptic ulcer in the stomach in a patient who's on high doses of NSAIDs for the last year. Pretty soon the stomach pain was worse than the back pain. All right, another area I expect you to know from your GI physiology. Again, if you need to go refresh this, go here. I'm going to go over it quickly, but I'm not going to go into the weeds on it. You can also, here's the exact page, so you can Google stomach gland physiology, who are they, in a Gillard, and it'll pop right up for you. But I will go over it a little bit. So again, there's three main types of stomach glands: cardiac, fundic, pyloric gland. We already talked about that. We already talked about cardiac glands are in the cardiac region. Fundic glands are found in the anatomical fundus and body. Remember, in pathology speak, we just say they're found in the fundic region of the stomach. Pyloric glands are found in the pyloric region, or the antral region of the stomach. All right, so here is a fundic gland, aka oxyntic gland. Terrible aka is gastric gland. I won't use that, but just beware of that. And it's got parietal cells, and it's got our chief cells in here. And yeah, and it's also got these important D cells, which we'll look at here in a second. Here's a pyloric gland in the pyloric region of the stomach. Their claim to fame are these G cells, which make gastrin. We'll take a look at how this all works. They also have D cells, their own D cells, which have a little different mechanism of action than these D cells do. All right, so main components of fundic gland juice. So what is the fundic gland? Very simple physiology question. I always remember hipster. Google says this is a hipster. So HIP stands for the juices that come out of fundic glands. There's hydrochloric acid, H. Intrinsic factor, I. P is for pepsinogen. Specifically, hydrochloric acid comes out of parietal cells. Intrinsic factor comes out of parietal cells. Pepsinogen comes out of chief cells. Got it? All right, now we're going to spend some time on this. It looks daunting, I know, but I mean, for boards, you need to know this thing. And you should already know this completely from GI physiology. So let's take that hamburger, thinking about a hamburger, smelling it or putting it in your mouth, or the hamburger stretching the stomach. They are all going to stimulate Meissner's plexus to release some stuff. Let's talk about acetylcholine first. So acetylcholine is released from Meissner's plexus, and it flows and binds to, let's do parietal cell first. It binds to it. The plus means it's a positive effect. Binds to M3 receptors on parietal cells. Causes the parietal cells to produce hydrochloric acid and intrinsic factor. The acetylcholine also binds to chief cells and causes them to produce pepsinogen. Okay, what else does acetylcholine do? It also binds to G cells in the pyloric antral region, in the antral region, and it stimulates the G cell to release its main hormone, which is gastrin. What does gastrin do? Gastrin swims over to the fundic region of the stomach through blood vessels, so it's a true hormone. It also circulates through every inch and nook and cranny of your body, and it binds to CCK2 receptors on parietal cells, does the same thing, stimulates hydrochloric acid and intrinsic factor. It also swims over and binds to chief cells and causes the production of pepsinogen. What else does gastrin do? It also swims over and binds to ECL cells, and much more powerful than PGE2. It overrides PGE2, stimulates ECL cells to produce histamine. Histamine then goes and binds to its H2 receptor on parietal cells, and that stimulates the production of HCl and intrinsic factor. Okay, what else does it do? I think that's about all the stimulating we need to do with it. There are some inhibitory actions of acetylcholine as well. Oh, there's one more thing. Acetylcholine can also go stimulate a mucose cell, which also helps drive PGE2. This is a late effect. After the acid is really flowing, this helps turn off the acid by the creation of PGE2. All right. So it also, another late effect here, a turning off effect, is acetylcholine can also bind to, let's do this one, it can bind to antral D cells. So antral D cells are a little bit different. They actually taste the lumen of the stomach for hydrogen ion content. But it also can, for right now, because we just ate our hamburger, right? We don't want to inhibit anything. So acetylcholine inhibits antral D cells from making their hormone, somatostatin. And we'll come back to that in a second, how to turn off. Because right now we want to make acid and intrinsic factor. So it inhibits the antral D cells, and it also goes over here and binds to pyloric D cells and turns them off as well. Okay. And I think that's all I wanted to say about that. Now, how do we turn off? So we got lots of acid flowing, and we're digesting our hamburger, and now it's getting too acidic. We need to slow down the acid because we don't want to cause an ulcer. The gastric mucosal barrier can only withstand so much. So when we get down to about a pH of 3.5 or lower, the hydrogen ions that are in the lumina of the stomach start stimulating the antral D cells to wake up. So these have little snake tongues, little receptors that float in the lumen of the stomach, within the gastric mucosal barrier actually, and they're tasting for hydrogen ion. When hydrogen ion gets too much, these wake up, and this effect is by now is turned off because once the machinery gets going, the acetylcholine stops flowing, and the D cells produce somatostatin, SST, somatostatin. Somatostatin swims over, it binds to G cells and shuts down gastrin production. Somatostatin is a hormone. It also gets in the blood, and it can go all the way over and shut off ECL cells, and it can also bind to parietal cells and shut them off as well. Okay. I forgot one thing. back on the hamburger again, when this is starting, not only is acetylcholine released from Meissner's plexus, something called GRP is also released. It's called gastrin-releasing peptide, and that stimulates the G cell. So there's a double stimuli mechanism here for getting gastrin released. All right, so we just shut all down the machinery down that way. There is a pyloric D cell, which is not tasting the luminal stomach contents, the acid contents. This one is a little more mysterious. It's thought that high levels of gastrin will wake this up. When pyloric SST, somatostatin, is released, it also can bind to parietal cells to shut them down. It also can bind to ECL cells and shut them down as well. All right, I think we got just about everything going there that I need to talk about. All right, I wouldn't worry about this one, but just worry about these main ones. All right, guaranteed questions. You want to know what to study? Study that, because probably at least 3 questions on there. All right, let's get into some pathology now. ZE syndrome, Zollinger-Ellison syndrome. Sometimes it's called gastronoma syndrome, but I think boards will call it Zollinger-Ellison syndrome. It's a condition which causes stomach upset and intestinal upset, and this one is the cause of it is there's an overproduction of hydrochloric acid and pepsin, for that matter, pepsinogen. What's the cause? It's caused by a tumor, a neuroendocrine tumor that secretes, lo and behold, gastrin. All right, and the bad thing about the tumor, there's no way to shut it down. It's not like G cells where you can shut the thing down with somatostatin and other things. So there's no way to shut it off, and it just overproduces gastrin. This tumor of gastrin-secreting cells usually is found in the pancreas. Therefore, it's often called a pancreatic gastrinoma. It can be in the duodenum about 10% of the time. The sequelae is, well, here's the sequelae. If you're over-secreting gastrin, I mean, I can make a tumor. Let's see, what color can I use? So let's see, we have the pancreas over here. And there's a tumor in it. And that tumor is secreting gastrin. The gastrin can get into the bloodstream, and it can get right into here. And just look, it can go just like the other gastrin does. It can bind to CCK2 receptors. It can bind to ECL cells, which creates histamine. So note that gastrin can both directly cause the release of acid by binding to CCK2 receptors and indirectly cause the release of acid by binding to ECL cells, which then release histamine, which bind to H2 receptors and stimulate the release of hydrochloric acid. So I often ask a question like that on the test. But yeah, so that's the story with that. Okay, in fact, there it is, directly binding and indirectly binding. Everything I just said. So what's the sequelae? Well, if you have too much acid produced in your stomach, as well as pepsin, you have a condition called hyperchlorhydria. I expect you to know that word. There's a vocabulary word. Hyperchlorhydria, which means you have too much acid being produced. There's too much acid. There's too many hydrogen ions, and the pH is too low in your stomach. So what? Who cares about that? Well, if you have too much acid and you have even a semi-weak lower esophageal sphincter, you're going to get GERD like crazy, and that can be, of course, converted into Barrett's esophagus, which can be converted, can progress, not be converted. GERD can progress to Barrett's esophagus. GERD can progress to esophageal carcinoma. And then you get stomach upset. You get dyspepsia, stomach upset, gastritis or gastropathy. Then you can get ulcers. You can get diarrhea as well, which we'll explain here in a second. Actually, the second is here. So what's the deal with that? So if you have too much acid in your stomach, you're going to have too much acid coming out into your duodenum, and your entire intestine is going to be the pH is going to be too low. You're going to have too much acid in your intestines. It's going to irritate the enterocytes, those simple columnar cells that line the lumen of the intestine. It's going to irritate them, inflame them, and they're going to get mad, and they're going to stop reabsorbing salt and water. And so you're going to get diarrhea. Instead of reabsorbing the water, that water's going to go out into the toilet. So your fecal material, your stools are going to be very watery, and that's diarrhea. Plus, you can get dehydrated. It could get so low you could start to get start to get hypotension, and maybe even slip into hypovolemic shock if this is bad enough. So what do you think the cells are going to look like? What cells are affected by gastrin? Well, parietal cells for sure get hit by gastrin. There's receptors there. And the ECL cells, the fundic cells, the fundic D cells. So they all are exercising all the time. So they're going to get big. They're going to become hypertrophic. And their rate of replacement is also going to increase. So they're going to proliferate. So there's too many of big muscular parietal cells and ECL cells. So that's going to make your stomach, especially where the rugae are, get really, really thick. And the rugae get huge in conditions like that. Symptoms are kind of talked about. These are, what are the patient's symptoms, though? Well, they're going to have tummy upset. So that's called dyspepsia. That's abdominal pain. About 75% of people with Zollinger-Ellison syndrome have dyspepsia. 75% have diarrhea. That's their complaint. And they, of course, can have both of these. 71% end up getting peptic ulcers. 44% end up getting serious heartburn. So what's the story? What's another problem that can happen? So if you have too much acid dumping into your duodenum and small intestine, the acid can deactivate pancreatic lipase, which comes out of the pancreas. We need pancreatic lipase to break down fats so we can absorb them. Without pancreatic lipase, you can't digest fat, and you have not only water going out into the toilet, watery stool, but you have really fatty stool going in to the toilet. And fatty stool has a look to it and a name to it. The name is called steatorrhea. Steatorrhea. Okay, it's a fatty stool. And warning, steatorrhea picture, but that's what it looks like. It looks kind of like clay. What's the natural history? Well, these people we saw the symptoms, but they can get severe ulcers in places that are difficult to treat. They can get them even in the jejunum, in distal, kind of the more distal than where they usually show up in the duodenum, but they can show up in the distal duodenum or even the jejunum. Sometimes they go into remission for strange reasons we don't understand. The only good thing about the disease, and I could ask you this on the test, we're going to talk a lot about H. pylori, which is a menace. The number one cause of chronic stomach pain is an infection with H. pylori. But people with ZE syndrome do not have H. pylori because the acid levels are even too much for that bug to handle, and it kills them. So ZE patients don't have H. pylori. How about some classical clinical findings? I always ask a question on this slide. Hypergastrinemia, so they have high levels of gastrin. They have hyperchlorhydria because of the gastrin. Gastrin drives the production of hydrogen ion. They have peptic ulcer disease and GERD that is refractory to treatment. So it's not treatable. You treat it with proton pump inhibitors and it doesn't work. On endoscopic, we'll look at that more specifically, but the ECL cells and parietal cells there's too many of them, and they're all buff and burly. They're hyperplastic. They're too big, and the rugae can even start to look too big. And, of course, they can have diarrhea and steatorrhea as well. Endoscopic appearance, we've already said. You get hyperplasia of the parietal cells, the fundic D cells, ECL cells, and it looks like this. Rugae are not supposed to look this massive. And this is a patient who has Zollinger-Ellison syndrome. All right, what's the treatment for this? Well, you got to try to treat the acid, so you can use proton pump inhibitors and H2 blockers to try to slow things down. Lifestyle adjustments, we've talked about that before. Diet and eating. Right is wrong. Don't sleep on the right side. Those same rules apply, just like as they had GERD. And then they're going to have to get a PET scan, a CT, MRI, cytography. You're going to have to find that tumor. And if it's big enough, you can take it out and the problem's solved. A lot of times it's so small it can't be found. And the pancreas is such a delicate organ. Sometimes it doesn't like to have things cut out of it. So it's kind of dicey. Remember intrinsic factor. Yeah, we remember that. Oh, we're going into vitamin B12 now. So just a review, remember intrinsic factor is also produced by parietal cells. Parietal cells are part of the fundic gland, aka oxyntic gland. And yeah, intrinsic factor's job, remember, is to bind to vitamin B12, and it's needed for vitamin B12 to be taken into the distal ileum. But let's expand on that. Let's go into this a bit. So now we're going into the weeds on vitamin B12. Cobalamin. There it is. I want you to know that structure. No, this is not biochemistry. You don't have to know that structure. But let's talk about it. It is a water-soluble vitamin. It's found naturally in animals and dairy products. It has many functions, but the two biggest ones, in my mind as a pathologist, are it is responsible for the synthesis of DNA, which is used for hematopoiesis, for building red blood cells and white blood cells, and all sites of all kinds of cells are built need vitamin B12. Right? That's also need to refresh myelin sheath around nerves. So myelin synthesis is also dependent on vitamin B12. And you can see next lecture we'll talk about what happens if you don't have vitamin B12, but you can guess. You're not going to have normal red blood cells, and you're not going to be able to refresh the myelin around your sheath, so you're going to get pain, spontaneous action potentials, and all sorts of nerves, and all sorts of problems. Interesting or fun facts about vitamin B12. The human can't make it, neither in plants or animals. So we have to eat it. Now, a side note, bacteria and algae can make it, and we have bacteria in our gut, so technically you can make a tiny, tiny bit of vitamin B12, but it's not enough to sustain life. But you can't make it. The bacteria that live in your gut can. So therefore, you are basically 100% dependent on eating eggs, liver, shellfish, sardines are high sources of vitamin B12. The other strange thing about vitamin B12, it can be stored. Let me say that again. Vitamin B12 can be stored, maybe up to a year, in the liver. Now that's weird, right? Because we probably learned in high school or undergrad that vitamin B12 is water soluble, so it can't be stored, but it actually can be stored in fairly large amounts. It can only be stored in the liver, but a year, maybe even 2 years worth can be stored. So the liver can act as a B12 reservoir if you're ever on a hunger strike. Okay, so rare example of a water-soluble vitamin being stored. Yeah. So where do pure vegetarians get their B12? They have to eat yeast, and I think there's other ways, but I think yeast is the big one. So big giant star here. you're going to be tested on this pathway. How do you get vitamin B12 into the bloodstreams? We're so dependent on it. First step is you have to eat an egg. You have to eat something that has vitamin B12 in it. Now, vitamin B12 in food is not just hanging out. It has a chaperone, and we're just going to call it food-binding protein. So vitamin B12 is bound to food-binding protein. You can chew it up all you want. You'll never dislodge vitamin B12 from food-binding protein. Talk about chewing up the egg. So that's called mastication. Again, it does not dislodge the vitamin B12 from the food-binding protein, but the process of mastication does stimulate the salivary glands to produce some important stuff beside the salivary juices. It stimulates them to produce something very important called holohaptocorin. I'm just calling it haptocorin for short. Technically, you should probably call it holohaptocorin. For medical students, it's R protein. Yamada is a text that those schools usually use or often use. Some call it R factor. Some call it trans-cobalamin 1. So it's one of those things where, who knows what they're going to call it. For chiropractors, it'll be called either haptocorin or holohaptocorin. Okay. So it's secreted from salivary glands, and it gets mixed in with the chewed up egg. Maybe some toast in there, eat an egg and toast together. It does not bind to the vitamin B12 yet. So you swallow your food, and down the hatch goes the B12. There's the triangle, or the B12 is the blue circle, with food-binding protein are combined. Down the hatch they go together. Haptocorin, kind of naked, goes down there together. And they go kerplunk into the stomach, into the acidy environment of the stomach. So in the stomach, it's not the acid that breaks loose vitamin B12 from food-binding protein. It's the pepsinogen. I've asked that question before. Basic physiology. So pepsin breaks loose food-binding protein. Vitamin B12 is now naked and afraid and won't live long in the acid environment if it doesn't get another chaperone. And we can already guess who binds to it. Holohaptocorin, or we're just calling it haptocorin, immediately binds to vitamin B12 and shelters it and protects it. B12 would be destroyed, as we said, by stomach acid if it doesn't bind to haptocorin. Okay, intrinsic factor, I don't think we need to remember it anymore, but we know that it's produced from parietal cells. Step 3. Okay, so haptocorin and B12 are ejected through the pyloric sphincter, and now they're in the duodenum. Intrinsic factor is also made and floating around in the stomach and also ejected. Intrinsic factor does not bind to vitamin B12 in the stomach. I will test you on that fact. I often test people on that fact. Okay, because it's bound to haptocorin. Haptocorin protects it from the acid, and now we're in the duodenum. Okay, and now the vitamin B12 and haptocorin pair are broken apart by trypsin and chymotrypsin, collectively called the pancreatic proteases. Okay, so almost immediately, vitamin B12 is naked and afraid again. Almost immediately, intrinsic factor binds to vitamin B12. So where does intrinsic factor and vitamin B12 finally hook up? Not the stomach, not the mouth, in the small intestine, specifically in the duodenum. Got it? And just a little side note, remember the pancreatic proteases, how those work from physiology. There's an enzyme called enterokinase. Sometimes it's called enteropeptidase. And this is not a free-floating enzyme. This lives on the cell membrane, on the brush border here of intestinal cells. And its job is to grab trypsinogen, chop its tail off, and create the active form of trypsinogen, which is trypsin. Right? Trypsin is catalytic. It can then take chymotrypsinogen and convert it into chymotrypsin. It's autocatalytic because it can take its precursor molecule, trypsinogen, and chop its tail off and convert trypsin. Right? So that's how that story worked. But anyway, back to the story. So we have intrinsic factor and B12 finally hooked up together, and they move through the small intestine together, and nothing happens for a while. But by the time you get down to the very distal part of the small intestine, the distal ileum, the last foot or so of the distal ileum, the combination of intrinsic factor and B12, it can hook up to cells, to simple columnar cells in the distal ileum. And specifically, there's a receptor called cobalamin, or I always think Batman, back when I used to watch him when I was little, they would, when he'd hit a bad guy, they'd always go kabam. So I always remember kabam receptors. So these kabam receptors are cobalamin receptors. They don't bind B12 by itself. They don't bind intrinsic factor by itself. They bind the combination of those two. And once they bind via endocytosis, intrinsic factor and B12 are taken inside the simple columnar cells that line the distal ileum. You could call them ileal enterocytes, if you will. Once inside a ileal enterocyte, something interesting happens. They bind to a lysosome. Remember, lysosomes are digestive organs of the stomach. The lysosome will break loose the vitamin B12. It will destroy the intrinsic factor and destroy the cobalamin receptor, but it doesn't touch the B12, which is kind of a miracle. How it escapes the wrath of the lysosome is a mystery. There's the little lysosomes inside of a cell, like the Death Star if you're a Star Wars fan. Very wicked. So what happens to B12? Now, it doesn't hook up with anybody inside the enterocyte. It gets spit out the bottom, not into the lumen of the intestine. It gets spit out into the interstitium, out the basolateral surface. And there's another partner it's waiting for. And this one's called cobalamin 2. So it binds with that in the interstitium, just underneath the epithelial cells of the enterocyte, or just underneath the enterocytes, or the mucose layer. And these two get sucked into the distal capillary of intestinal veins. And then they go through the superior mesenteric vein, hepatic portal vein, and they're in the liver. Remember your anatomy. So here's the distal ileum here. Remember, there's those small intestinal veins. I'm not showing the capillaries, but the capillaries would be all over the place. And the venules they're the venous part of the capule. The distal capillary is kind of sucking on the interstitium, and it sucks up cobalamin 2 and the vitamin B12, and off it goes. It goes through the superior mesenteric vein, and it goes through the portal vein, hepatic portal vein, and now you're in the liver, which is the target, right? That's where all the storage is. Here's just a cartoon of that process. Okay, so it goes to the liver, some goes to the bone marrow, some goes to nerves. And yeah, that is the story there. Recall B12 is needed for DNA synthesis in hematopoiesis, and in DNA synthesis in myelin sheath repair and regeneration. So those are the two things that get affected when you're deficient in B12, which we'll talk about next time. Is there another way to get vitamin B12 in the bloodstream? Well, there's one terribly efficient way. If you megadose vitamin B12, you can get maybe 1% of that megadose into the bloodstream. It's not enough to sustain life in someone who's not getting vitamin B12, but it can certainly keep them going for a while. And someone who is vitamin B12 deficient, megadosing vitamin B12 is a precursor. It'll keep them going, but as the condition worsens, they're ultimately going to need B12 injections. All right, I think I said this already. So we can use this 1% absorption of vitamin B12 to kind of hold off cases of pernicious anemia, which we'll talk about next time. All right, that's called superdosing vitamin B12, by the way. All right, thanks for watching, and here's our bird that I've been known to throw on tests before. I think you should know the environment, the creatures that are around you. This is, I talked about going to El Viso Marina Park just a couple days ago, and right in the parking lot, sitting on a light pole, was a beautiful red-tailed hawk. See you later. Email me those questions. We got our test coming next week. Oh, that's in CVP, though. But email me questions about this, too.